Welcome back to next video, video 5, here for the endocrine system. So in this video we're going to be going over the thyroid, normal anatomy, physiology, and pathologies. We'll also go over the parathyroid gland, since that is in immediate proximity to the thyroid gland. All right. So we start off with the thyroid gland. So this is going to be one of the many department head hormones that we will encounter in this chapter. So remember your, excuse me, not department head hormones, department head glands. Remember that the department head glands are under the influence of the pituitary, and then the pituitary is going to be under the influence of the hypothalamus, which will release either a releasing or a non-releasing hormone. So the thyroid gland is inferior to the larynx, otherwise known as the Adam's apple, at the base of the throat. Here it lies at the front and sides of the trachea. The two lobes are divided by a center band. I don't know what's up with all of the typos. Center band of tissue called the isthmus. Okay? So this is that central band of tissue right there. The thyroid gland will release 3 hormones, T3, T4, and calcitonin. There are the full names for T3 and T4. We will talk about the structural differences between those two in just a few moments. These hormones that the thyroid produces will drive our metabolism. Okay. So here we see more, just a close-up of anatomy here for the thyroid. Again, we have the isthmus, that central band of tissue right there. Since this is the right and this is the left, okay, over here you have your right lobe, and then over here is your left lobe. Okay. And you see the thyroid over here in a cadaver, again forming that butterfly shape. Okay. All right, T3 and T4 are responsible for controlling the rate of energy metabolism and heat production in the body. Remember that we have certain biogenic amine hormones that come from either tryptophan or tyrosine. And remember the example I gave of some of the hormones that come from tyrosine are T3 and T4. Okay, so just making that link back to what we talked about before. The follicular cells of the thyroid will secrete T3 and T4 into circulation. These hormones are formed from the 2 linked tyrosine amino acids with iodine atoms. Okay? Oh, excuse me. So essentially what happens is you take 2 tyrosine molecules, you attach an iodine, and you get T1, or monoiodotyrosine. Okay. So T1 and T2, which would be 2 iodine molecules, are precursors to thyroid hormone and biologically inactive. So really don't do anything with T1 and T2. They are the building blocks for T3 and T4. Okay. So So down here you see T3 and T4. T3 has those three iodine molecules. T4 has 4 of them. Okay. And then back here, if you also look back here, I refer to T4 as thyroxine. You actually call T4 thyroxine or tetraiodotyrosine. Okay, so that's its technical name, but you can also call it thyroxine. So T3 is going to be the more powerful form of thyroid hormone, and it is biologically active. T4 is more plentiful or abundant, and it is biologically inactive. Okay? T3 more powerful, active. T4 more plentiful, inactive. The iodine required to make T3 and T4 comes from our dietary intake, which is why salt is fortified with iodine in many countries. Iodine is also found on the following foods. So you can find iodine in seafood, including fish and shellfish, shrimp, crawfish, crab, lobster, things like that. Seaweed, dairy products like cow's milk, cheese, and yogurt. Eggs, corn, prunes, and lima beans. Okay, so you can see here, salt usually is fortified with iodine, so that we can have that that steady supply of iodine in our diet. Okay. All right, so we saw this similar picture for what was it before? I think it was cortisol. Is that it? No, it's for growth hormone. I'm sorry. So we went over this diagram for growth hormone. Now we're going to go over it for thyroid hormone. Okay. So again, here is our image. What we're going to essentially describe what is going on in this image on this slide. Okay. So thyroid hormone is regulated by hormonal stimulation by the release of thyroid releasing hormone from the hypothalamus. So that is the specific releasing hormone that comes from the hypothalamus, TRH. TRH, so back here, we have the release of TRH right in here in the hypothalamus. TRH will enter the hypothalamo-hypophyseal portal system, which is a venous system, meaning that blood will be heading back to the heart. So that is essentially what is going on in 1, 2, and 3. TRH making its way down to the pituitary through that portal system. TRH will bind to the receptors in the thyrotropic cells of the anterior pituitary and stimulate the release of thyroid stimulating hormone, or TSH, into general circulation. And that is what we see here in number 4, the release of TSH from the anterior pituitary, which will make its way down like so. TSH will then bind to the follicular cells of the thyroid gland and stimulate the release of thyroid hormone. So when I use the abbreviation TH, I'm talking about T3 and T4. Okay, just wanted to make that clear. T3, remember T3 is your more powerful and active form of thyroid hormone. that will target effector organs and institute a myriad of effects. So we see thyroid hormone heading its way down here into the bloodstream, and then down here we're going to have a whole host of other effects. Also note here, we're going to go over it on the next couple of slides, but note that thyroid hormone can feed back to both the pituitary, and the hypothalamus to have inhibitory effects. Very similar to how, let me scroll back here, growth hormone, okay, fed back to shut down the pituitary and the hypothalamus, shut this whole system down. Okay, so you see how similar this system is with the releasing hormone from the hypothalamus, the tropic hormone from the pituitary, and then your target cell or target tissue. Okay, and yeah, actually, you used the wrong terminology here. So growth hormone is not tropic. Growth hormone is non-tropic because it's acting on tissue directly. But where are we? Here, TSH, that is tropic because it's acting on another endocrine organ. But I just wanted to show, compare and contrast there so you could see how similar the pathways are. All right. That's it there. Oh, I included this image over here just because, so thyroid hormone is what we call permissive in general, meaning that it is going to allow a host of different things to take place and happen in the human body. We'll get to another hormone later, cortisol, which is going to be what we call permissive under stress. But just wanted to introduce that concept now. Okay, so we have T3 and T4 in circulation. It will have a host of different effects on all different types of tissues. Excuse me. So in most cells, we'll have an increased metabolic rate. We'll have increased glycogenolysis, okay? So glycogen and then breakdown. So breakdown of glycogen and gluconeogenesis, new creation of glucose. Both of these things collectively will lead to increased glucose levels. Because when you break down glycogen, you get glucose, and when you form new glucose, you get glucose. Okay. Also, decreased glycogenesis. Okay, so glycogenesis, formation of glycogen. So, decreased formation of glycogen, increased breakdown of glycogen, and increased formation of new glucose will lead to increased levels of glucose. Okay. Also, fat in the adipose tissue get increased lipolysis that will release glycerol and fatty acids into circulation. So we see a lot of effects here that are very similar to growth hormone. And then decreased lipogenesis, or decreased formation of fat. I don't know why it keeps doing that. Lungs. So we'll have an increased breathing rate, increased heart rate, and increased force of contraction. Okay. So the net result of all of this is increased metabolic rate and increased nutrient release into the blood. So your nutrients here, glucose, glycerol, fatty acids. Okay, so those are all nutrients. Increased T3 and T4 levels feed back to inhibit the hypothalamus from releasing TRH. They also inhibit the pituitary from releasing TSH. So that's what I was talking about before with the negative feedback. Other stimuli, in addition to the blood levels of thyroid hormone, will influence the release of TRH from the hypothalamus, and these include cold weather, and we'll talk about each one of these in detail, pregnancy, high altitude, and hypoglycemia. Let's go through each one of these and talk about their effects on, the effect of TRH on, the effect that all of these have on the release of TRH from the hypothalamus. So cold weather, so TRH and TH levels will increase under the influence of cold weather. Okay, we're not sure exactly why this happens, but cold weather will cause an increase in TRH and thyroid hormone levels. Pregnancy, so thyroid hormone levels will increase mildly because beta human chorionic gonadotropin, otherwise known as beta HCG, this is the substance or hormone that is made by the growing placenta, and this is what will leak into the urine, and this is what pregnancy tests will detect as beta HCG levels. But beta HCG structurally is very similar to TSH. Okay, so essentially what will happen is the beta HCG will make its way to the thyroid instead of TSH and cause the thyroid to release more thyroid hormone. You have beta HCG, which will act exactly like TSH and cause that thyroid hormone release. Okay, so that's why you have increase in thyroid hormone levels in pregnancy. High altitude. Remember, if you're in high altitude, that means you have low oxygen levels, and this leads to an increase in thyroid hormone levels without an increase in TSH or TRH levels. Okay? And the mechanism is not clear, but it does not appear to involve the hypothalamic pituitary axis. So essentially that low oxygen will just cause more thyroid hormone levels to, will cause thyroid hormone levels to increase. And then lastly, we have hypoglycemia. Extreme hypoglycemia will trigger the release of cortisol, and repeated release of cortisol will lead to pituitary hypofunction, which can lead to decreased TH levels. So essentially, the bottom line here for these four factors: cold weather will increase thyroid hormone levels, pregnancy will increase thyroid hormone levels, high altitude will increase thyroid hormone levels, but hypoglycemia will decrease thyroid hormone levels. All right, let's talk about, calcitonin and PTH. So calcitonin, remember, is that third hormone released by the thyroid gland along with T3 and T4. Calcitonin is produced and released by the parafollicular cells of the thyroid gland. Okay, so your follicular cells of the thyroid gland, those produce T3 and T4 under the influence of TSH, thyroid stimulating hormone from the pituitary, Your parafollicular cells in the thyroid gland will release calcitonin. Okay? So the parafollicular cells are located between the follicular cells in the connective tissue of the thyroid. Calcitonin is involved in maintaining calcium homeostasis and is released when blood calcium levels are high. Calcitonin, blood calcium levels are high. Okay. It is also released in response to stress from exercise. So this is what we refer to as a stress hormone, one of many stress hormones. The other hormone involved in calcium homeostasis is parathyroid hormone, or PTH. Okay? And essentially what's going to happen is calcitonin and PTH will act in opposition to one another, but we will see that they act in opposition to one another, but they work together to maintain that calcium homeostasis. Okay. So here you see the parafollicular cells and follicular cells at the histologic level. Again, parafollicular cells will produce calcitonin. Follicular cells will produce the thyroid hormones. And you can see the colloid in between each one of those. Okay. So the parathyroid glands, remember, two pairs of glands located on the posterior aspect of the thyroid. These glands secrete parathyroid hormone in response to low blood calcium. So PTH will increase blood calcium in 3 ways. So before we get to this, once again, PTH is released in response to low blood calcium. Calcitonin is released in response to high blood calcium. So what this means is kind of a concept to keep in mind moving forward. Okay, we talked about 2 different types of cells in the thyroid gland that are responsible for producing the 3 different types of hormones that come from the thyroid. We got T3, we got T4, and we got calcitonin. Okay, so I want you to pay attention to what I'm about to say so you kind of get a good handle on this. So T3 and T4, okay, they are released from the thyroid under the influence of thyroid stimulating hormone. Thyroid stimulating hormone comes from the anterior pituitary, okay? And thyroid stimulating hormone is released from the pituitary when thyroid releasing hormone is released by the hypothalamus and makes its way down. So the release of T3 and T4 from the thyroid is under the hormonal arm of hormone regulation. Okay? However, when the parafollicular cells of the thyroid release calcitonin from the thyroid, okay, that doesn't come as a result of hormones from the pituitary. So there's no hormone from the pituitary that makes its way down and causes the release of calcitonin. What causes the release of calcitonin is the detection of high blood calcium. So what that means is that the release of calcitonin from the parafollicular cells of the thyroid falls under the humoral arm of hormonal regulation. And very similarly, the release of parathyroid hormone from the parathyroid glands on the posterior aspect of the thyroid will also fall under the humoral arm of hormone regulation. So you have two different arms of regulation, hormonal and humoral, in the same gland. All right. All right. So that's good. Good physio right there, and application of some of the concepts that we have covered already. But PTH will increase blood calcium in 3 ways. Okay, so you have low blood calcium, PTH is released, you get increased calcium levels. So number 1, PTH is going to stimulate bone breakdown by osteoclasts. Remember our friends, the osteoclasts from last semester, thereby moving calcium from the bone into circulation. As you break down bone, you produce, you essentially harvest all of that stored calcium, and you toss it into circulation. So that's one way PTH can increase blood calcium. Number 2, can increase calcium absorption in the small intestines with the aid of vitamin D. This is why calcium and vitamin D are often mentioned together, is because without vitamin D, the small intestines cannot absorb calcium. Okay? So if you increase calcium absorption in the small intestines, that's going to lead to increased calcium. Also, you can stimulate calcium reabsorption in the kidney from the urine. Okay, so all 3 of these things will increase blood calcium. So if you look here, this is, we're going to see a diagram like this when we talk about blood sugar regulation. But essentially what this is depicting, here is homeostasis. This is normal calcium levels in the blood. This is what we want to maintain in the blood. Is this homeostasis or physiological balance? Okay. If calcium levels get too high, then calcitonin is released from those parafollicular cells of the thyroid. That will cause increased calcium deposition. Okay, so think about this. We just went through 3 methods by which, on this slide, 3 methods by which PTH can increase blood calcium. Okay? Calcitonin is going to utilize those 3 methods as well. So instead of increased osteoclastic activity leading to bone breakdown, we'll have increased calcium deposition. We want to get that excess calcium out of the bloodstream. We're going to take that, we're going to store it in bone. So this is method number 1. Method number 2 involves the GI tract. So we will decrease calcium uptake in the intestines. Okay, we already have excess calcium in the blood. We don't want to take in any more calcium by absorbing it in the intestines. And then number 3, we will have decreased calcium reabsorption from the urine in the kidneys. These 3 things in the face of high calcium levels will lead to calcium levels falling. And that will bring us back to homeostasis. Okay? If calcium levels get too low, down here, now we have the release of PTH from the parathyroid glands. That will cause increased calcium release from bones. So this number 1 over here is this number 1 right here. Okay? Stimulate bone breakdown by osteoclasts, move calcium from the bone into circulation. Number 2 right here, increased calcium uptake in intestines. That is this number 2 right here. And then this number 3 is this right here. Okay? All 3 of these things will lead to increased calcium levels and a return to homeostasis. Okay? So even though calcium and PTH act in direct opposition to one another, by their combined effects, they, you can be said that they actually work together to keep calcium levels normal. All right. Okay, let's go through our thyroid disorders. And then I think that will bring us to, yes, that'll bring us to the end. So we only have a couple slides left in this particular video. Now, the thing to remember about hyperthyroidism and hypothyroidism, okay? If you have, let me start here. Thyroid hormone, okay, is essentially going to be permissive in general. So what thyroid hormone does, it increases pretty much everything. Makes everything more active, and its effects are, wide-reaching all over the body. So if you have hyperthyroidism, okay, you're going to start to think, what I want you to think about are symptoms that reflect a revved up or supercharged human body. Okay, so we'll get to that in a second. But hyperthyroidism, or an overactive thyroid, characterized by a visibly enlarged thyroid gland in the neck. The enlarged gland is called a goiter. So this is a goiter right in here. Okay. The goiter is caused by an insufficient amounts of iodine, which is required for the production of thyroid hormone. What the thyroid will attempt to do is produce excessive amounts of the thyroid hormone to obtain more iodine. The thyroid doesn't know that there's no iodine present, so it's going to keep churning out thyroid hormone. And as a result of that increased activity by the thyroid, you get the goiter. Okay? For that reason, it's extremely uncommon for goiters to be found in developed countries. Why is it extremely uncommon for this to be the case? Because in developed countries, salt is fortified with iodine. The absence or decrease levels of iodine is what is responsible for this goiter appearing. Okay. So remember we talked before about how I wanted you to think about what symptoms you would see if the body was supercharged and revved up. So that will include increased heart rate, increased blood pressure, body temperature, hyperactivity. You will have weight loss because if the body is supercharged, if it is more active than usual, then it's going to shed pounds, it's going to shed fat. Okay. Heat sensitivity, so sensitivity to heat, diarrhea, because diarrhea represents an overactive or supercharged digestive or GI tract, and then difficulty concentrating. Your mind is racing all the time as a result of the increased T3 and T4. Other causes of hyperthyroidism besides iodine deficiency will include non-cancerous growth of the thyroid gland, inflammation of the thyroid gland, or an autoimmune disorder of the thyroid gland, which we're going to talk about on the next page. Treatment for hyperthyroidism, medications to release thyroid hormone, and or surgery to remove a overactive thyroid gland. So back here, when we talked about the autoimmune disorder of the thyroid gland, this is that autoimmune disorder that can cause hyperthyroidism, so Graves' disease. Most common cause of hyperthyroidism is Graves' disease. So this is an autoimmune disorder that leads to an overactive thyroid gland. Okay? Graves' disease will cause the eyes to bulge outwards. We call that condition exophthalmos. Okay, so right in here. If any of you have seen or watched Wendy Williams' show, I'm not sure what network she was on, but she has Graves' disease. And if you look at her face, you can see a very clear example of exophthalmos. Okay? This may make it difficult or impossible to close the eyelid, which can lead to drying and scarring of the cornea. Okay? Treatment for Graves' disease is the same as that for hyperthyroidism. So medications and surgery. Hypothyroidism, on the other hand, is an underactive thyroid, usually caused by thyroiditis, which is inflammation of the thyroid gland. And thyroiditis also can be caused by an autoimmune disease, namely Hashimoto's thyroiditis. Can happen after a cold, respiratory infection, postpartum thyroiditis. So after a pregnant woman has delivered, she can experience inflammation of the thyroid and also prescription drugs. Notice here that the symptoms of hypothyroidism exact opposite of those of hyperthyroidism. So instead of increased heart rate, you're going to have decreased heart rate, decreased blood pressure, decreased body temperature, hypoactivity. I think in your notes, I included some. So 5, I think in there is constipation. Okay. Constipation, diarrhea represent different ends of the spectrum. So constipation is an underactive GI tract. Diarrhea is an overactive GI tract. So you'll see that here. Also, weight loss. I'm trying to remember what else is over there. Okay, so you'll have constipation instead of diarrhea, weight gain. I'm sorry. You have weight gain instead of weight loss. You'll have cold sensitivity. And then what was number 8? Difficulty concentrating because your mind is racing. You can also have difficulty concentrating here, but for an entirely different reason. Your mind is not racing; it's underactive. Okay. So those are your symptoms of hyperthyroidism. Instead of medications and surgery to decrease thyroid hormone levels, since here we don't have enough thyroid hormone, we can just give them medications to replace that T3 and T4. Okay. Adults with undiagnosed or untreated hypothyroidism can develop myxedema, which is a severe form of hypothyroidism that causes swollen puffy face, dry skin, and decreased mental acuity or sharpness. Okay. This can be treated with an oral form of T4 called Synthroid. Okay. Newborn children can also develop neonatal hypothyroidism. This is one of the many conditions that newborn babies are tested for before they can leave the hospital. Okay? So dull, dry skin and brittle hair are common. Early diagnosis is key because if it is caught early enough, it can be reversed. Okay? You treat that with an oral form of T4 as well. All right, last slide. So our parathyroid disorders. Since PTH deals with calcium regulation, for parathyroid disorders, we will have hyper and hypocalcemia. Okay? So in hypercalcemia, we have a hypersecretion of PTH, causes increased calcium in the blood, or hypercalcemia. Okay? This can lead to increased calcium absorption by the kidneys. And the mnemonic to remember the symptoms of hypercalcemia is stones, bones, groans, and psychiatric overtones. Okay? So stones, bones, groans, psychiatric overtones. The term stones refers to kidney stones because of the increased calcium absorption by the kidneys. The term bones refers to very painful bones because of the increased calcium deposition. It will make the bones very dense and heavy. It's going to make them painful. Okay? Groans, nausea, vomiting, constipation, and indigestion because of all of the calcium in the GI tract. Psychiatric overtones is going to be memory loss, psychosis, depression, and fatigue because of all of the calcium depositing in the brain. Okay? So stones, bones, groans, psychiatric overtones. Treatment, hydration via IV fluids. If you have too much calcium in the system, you essentially drown everything out. Okay, so you just hydrate them, and that will bring the calcium levels down. If you have hypocalcemia, on the other hand, here's where we have a hyposecretion of PTH, which will cause decreased calcium in the blood, or hypocalcemia. This will lead to unstable nerve and muscle membranes that will continuously fire electrical signals. The result of this is a sustained muscular contraction, which is called tetany. Okay? If left untreated, tetany can lead to asphyxiation and death. Treatment for hypocalcemia is PTH replacement, and then calcium and vitamin D, since they don't have that in circulation. All right, this wraps up video number 5. In video number 6, we will talk about the thymus, the pineal gland, the adrenal gland, go through some more disorders. Yeah, then we'll we'll stop at adrenal disorders. And then for video 7, we'll talk about the pancreas. That's when we'll get into talking about diabetes. And yeah, we'll talk the gonads and the minor endocrine organs. And then the last video, which will be video 8, we'll go into hormone interactions and the stress response. All right, so it'll be 8 videos total for this chapter. Just finished video 5. We got 3 to go. So see you in the next video. Take care.